Okay, hello everyone. So, if you have any questions, throw them into chat, and then I'll answer them as we get them. Hope everyone's doing well with the studying so far. Okay, first question. Peripheral diseases, almost sudden onset. Okay, so talking about peripheral disorders. And 19. Okay, so peripheral disorders, nystagmus. The latent period here is what you're talking about. Okay, and so I'm trying to see where the other one is regarding the peripheral disorders, but go by this table is the one to go by. Because I used this one for any questions I had, so that's the one I used. So go by that one. Next question is regarding Lambert-Eaton with increased strength with muscle strength while myasthenia gravis does not. So let's talk about what's going on with these two different diseases. Lambert-Eaton disease is a problem with the calcium channel. So Lambert-Eaton attacks that. So we prevent calcium release, but all of the neurotransmitters for acetylcholine are just fine. They can get out just fine. So the problem isn't with Lambert-Eaton. The problem is not with anything to do with acetylcholine. The problem is with those calcium channels. So if you can give things to mimic or to dump more neurotransmitter into the cleft, then they get better strength with it. So I hope that answered that one with regards to the myasthenia gravis, but with Lambert-Eaton, but with the myasthenia gravis, remember myasthenia gravis is a problem with the acetylcholine receptors. So myasthenia gravis knocks them out, so less acetylcholine can do things so they fatigue out faster. Motor function at the level of the injury with Lambert-Eaton. Let's go to a different. Okay, all Brown's acquired. At the level of the injury. So when it comes to Brown's acquired, it gets very confusing when it gets to at the level of the injury. That's why I say just know that one picture. Where is it? Here we go. So at the level of the injury. So at T10, lower motor neuron lesion occurs. Why is that? At T10, at the level Okay, we have our upper motor neuron comes down in the cortical spinal tract, crosses into the anterior gray horn, where it's going to synapse with the lower motor neuron, which then leaves and comes out of the ventral horn, ventral nerve. When we obliterate it, we destroy the outlet and everything. So basically, the lower motor neuron doesn't work and nothing can leave, nothing tells it what to do, so it gets very haywire. That's really what's going on at the level of the injury in Brown-Séquard. Below the injury, okay, so it says sudden onset vertigo, but late in nystagmus. Okay, so sudden onset of vertigo is I feel the room spinning, I feel the room spinning. The nystagmus is when you start seeing the eyes move. So those are the two things. Make sure you separate those out. What's the next one is? Level of the lesion for ascending pathways. So at the level of the lesion, we lose all sensations at the level of the lesion. Nothing can come up with our proprioception. 2 point wants to come up. What's the color? Proprioception wants to come up. Can't. Pain and temperature wants to come up and then cross over. Can't. So at the level of the injury, everything gets lost. So just remember these things. Just remember at the level of the injury, loss of all sensation, lower motor neuron, and then what happens on each side. Okay, so talking about different treatments regarding diabetic neuropathy. Let's go to that one. So again, anytime you talk about diabetes, the biggest thing in the beginning is always getting that sugar under great control. After that, then you're worrying about signs and symptoms. Where's the peripheral neuropathy? This is MS. There at the end. Okay. So the question is, so the systemic effects we're talking about is just what happens when you have uncontrolled diabetes. So they're going to have gastroparesis, so you need to give them other things to watch out for. It's mainly all falling under this autonomic dysfunction. So if it's only if they have urinary incontinence, then bethanechol is a great one to use. If they have gastroparesis, then you can give metoclopramide for that. If they have orthostatic hypotension, you can try other things first, but fludrocortisone, the volume expander, is another good one you can use for that. So these are all treatments if they have these problems. And remember, always number one is going to be this tight control of serum glucose. Number one, always get that sugar under control. Okay, next one is talking about cerebral palsy versus muscular dystrophy. So, muscular dystrophy, progressive is the key thing here. Muscular dystrophy is a progressively worsening muscle weakness and wasting. So, it's going to get worse as they get older. Cerebral palsy is non-progressive, and where did I have it? No, here it is. Non-progressive. So cerebral palsy is due to developing fetal infantile brain that results in the problems that they have with the muscle problems. But it just happened during development and then it stopped. So it's not progressive. It's not going to get worse. It's just not going to get any better either. So a lot of these managements are due to just all patient education and other comorbidities. And MS and vertigo. It's all due to not really vertigo per se, but it's also balance issues. So remember with MS, the cane, where is it? There we go. Vertigo. It's right there. Due to the weakness, remember with multiple sclerosis, it's anywhere, time and space. So any lesion along the brain, spinal cord, will cause issues. So depending on where these lesions occur, you're going to have those symptoms wherever the lesion is occurring. So there's a lot of different symptoms. A lot of them have common ones that happen along the way. The big thing for CRPS is basically understanding this part, type 1 versus type 2. Understand the big things are this pain out of proportion, where you look at their exam, they're not in that much pain, but they're really they're in a lot of pain, but on your physical exam, x-ray findings, you don't really see much. But they're in a lot of pain. As far as treatment, these are the big ones. Early in the course, pain management, NSAIDs. If you need the TCAs, you can add them later. Or those gabapentins for that neuropathic pain. Okay, pronator drift. Too thick. Okay, so arms are up and then they fall. Contralateral because, this is a bad picture of the brain. If they're, this is right, that's the left side. If the left arm falls, this motor nerve is here, goes up to the brain. When it gets to the medulla and those pyramids, crosses over and goes to there. That's why if it's the left arm, it's the contralateral side that you have the issue on. Okay, the next one is patient had a problem with a dorsal white column, deficits in the neck. It would have to be a question about so dorsal white column. So remember, it's sacral, lumbar, thoracic, cervical. As far as how all the cables come in. So, because if I said that someone has problem with the neck, because the neck is our cervical spine, I know the cervical vibratory sense or 2-point discrimination is going to be on the inner part, the gracilis is going to be affected by that, because I know that my cervical or my hands are getting numb or proprioception's off, not vibratory sense. I can't feel anything in my fingers. Those, C4, C5 nerve roots, they're going to go all the way up to my neck. So I know those are cervical because it's C4, C5 nerve roots. So it has to be a problem with the gracilis because that's the part that has those nerve fibers in it. If I had my big toe, I can't feel any vibratory sense there. Cuneatus, and that's the lateral portions. That's where the sacral and the lumbar cords come into play. So that's where I want you to know as far as this dorsal white column. Know the anatomy, know the order of things in which way they are, and they're oriented. So if I say, you got laterally stabbed on this one, what you're gonna feel, well, what sensation would you lose first? Now remember, for the other ones, the anterior and the lateral spinal thalamic tract, it's the opposite. It's cervical, thoracic, lumbar, sacral. It's the other way first. So if I said we got stabbed this way, in that portion, laterally going in, cervical and thoracic are going to be the first ones that will feel the lack of sensation, and then it's going to go from there. Okay. So if there's a lesion at the right T10 for pain and temperature, at the level of the lesion, will lose pain and temperature. If there's a lesion at right T10, they will lose the contralateral size below the lesion. So they will lose contralateral below the lesion. So why do tumors cause pain that's worse at night? So let's go to this one. I'll show you a picture. This is a herniated disc. Maybe it's in this one. Okay. So when you go to bed at night and you go to sleep and you lay on your back, compression is going that direction. This is your, back. So you're compressing on that tumor, which is compressing your spinal cord, which is going to cause pain, shooting down everywhere else past all that. Let me go back and make sure I didn't, hold on. Okay, did I draw that wrong? Hang on, let me go back to that. No, not that one. Hang on, let me go to this one. This one has it. Okay, so I'm sorry. You guys are right. It is the opposite. This is the correct way. So thanks for bringing that up. So gracilis, yes, is sacral, lumbar. Cuneatus is thoracic and cervical, and then it's the opposite direction for the other two tracks. So thank you for bringing that up. Sorry. Pronator drift. If the problem's on the left side, and this is a motor problem, the hand can't keep it up, so your arm is drifting. If it's the left side, that left arm is having the problem, that motor nerve comes up, crosses over, that's the medulla right there, and crosses to the other side. That's motor. Motor crosses over at the medulla, so it's the right contralateral side. Noel, does that answer your question about the pronator drift? Let me just make sure. Where is it? Yeah, contralateral side. Okay. I think we're caught up on questions now. Okay, lower motor neuron versus upper motor neuron damage. Is it in this one or? That's not it. Where's that picture? Was it in the HMP one? Nope, not this one. You remember, where was this chart? What lecture was it in? It was lecture one. It was after all this stuff. Here we are. Okay. So this is talking about the muscle. So what is going to happen to our bulk of our muscle? If we have an upper motor neuron damage, the bulk, when you do your squeezing of all the muscles as you go through everything, is going to be normal until over time, because the upper motor neuron is not telling that lower motor neuron what to do, you get disuse atrophy. So it's going to be normal at first, then it goes away. If you have a lower motor neuron damage, prominent weakness and atrophy occurs early because the lower motor neuron is damaged now. It's not telling that muscle what to do, so eventually that bulk is going to go away. Tone. With an upper motor neuron, they're going to have increased tone on their muscles in the area that's affected with the upper motor neuron. So wherever that upper motor neuron is damaged, those are the muscles that you're going to have problems with. Except when they have spinal shock, where they're going to have that tone will be flaccid and hopefully recovers. In a lower motor neuron, they're always going to be hypotonic. Remember that, immediate, flaccid paralysis. The power of that muscle, how much they're going to be able to squeeze. So when you tell them, squeeze my fingers on your physical exam, how much power are they going to have in squeezing your fingers or resisting you in doing your active range of motions? How much muscle strength they're going to have? What kind of power are they going to have? Reduced in upper motor neuron because that lower motor neuron is still there. Severely decreased power because that lower motor neuron will never stimulate that muscle and it won't do anything. Abnormal movements. What kind of things they're going to have? No fasciculations with an upper motor neuron, but they will have fasciculations, so twitching. When you guys do your physical exam and you're looking for any muscle fasciculations, you're looking for muscle twitches. What is going on? That indicates a lower motor neuron if they have fasciculations. Reflexes. Brisk reflex with an upper motor neuron disease. It's still going to be there because remember with a DTR, the deep tendon reflex, it comes in the sensory. There's a small little interneuron there, but then it jumps right onto that lower motor neuron and it goes right out. So it kind of really bypasses the upper motor neuron. So you're going to have a little bit of a brisk reflex, but decreased to absent reflexes with that lower motor neuron disease, because now you truly are testing that lower motor neuron when you do your reflex. And when the lower motor neuron is absent, or not absent, but it's destroyed or damaged, that arc can't happen. And finally, our plantar Babinski is upgoing toes. Remember that Babinski is considered a brain reflex. It goes all the way up to the brain and has to come back down. So the coming back down of the motor, which is the upper motor neuron, is damaged, causing you to have an abnormal response for your Babinski, which is now going to be upgoing. In a normal response, we know what they are. In a lower motor neuron, they're going to be downgoing. So I hope that answers the question about the upper versus lower motor neuron damage and what kind of symptoms they're having. So when you get to different questions, if I mention anything about hyperreflexia, it's an upper motor neuron. If I say anything about hypotonia, muscle atrophy in the area that's affected, it's going to be a lower motor neuron, and so forth. Now, also, don't get confused. The upper motor neuron is only if, they have an issue with the upper motor neuron that goes all the way down to their, down to the foot. So it's whatever areas are affected is where you're going to have these problems, not the whole body. Yeah, they can have, so with ALS, it's a mixed, so they will have tongue fasciculations is a big one, and then they get muscle weakness, not so much the hyperreflexia, but They get the tongue fasciculations, and they get also some hyperreflexia. Let's go to the ALS one. Oh, neuromuscular junction. Okay. Weakness, normal sensation. Remember it. So sensory is okay for these patients. That's that one. That's the cortical bulbar. Tongue fasciculation is a classic finding. We destroy all that, so those synapses can't occur. That's really all I had for that. Okay. Lower motor neuron deficits with an epidural spinal cord compression. Let's go to that one. Okay. Oh, so they get lower motor neuron because nothing's telling it what to do. Oh, lower the music, sure. Okay. Um, just compression of these, same way that they compress on these posterior nerve roots, they can compress the motor nerve roots as well, which is the lower motor neuron. When it leaves, where's a picture? This, not that one. So hit this one. So let's say we had a tumor here. It'll compress the sides there and it causes the problem. It's not so much, it's just actual compression itself of the nerve. If it, oh, it's going to be on this side. But if it compresses, if the spinal cord tumor comes out this way and compresses on the nerve roots, it's going to cause problems. So it just depends on where the compression occurs. Like in this case, you see how we have this propulsus here, which is pushing on the motor side first. So you're going to get motor weakness and problems. But if it keeps going, now we've involved the sensory problem as well. So with herniated discs, you get the mixed sensory motor problems because of the issues. All the questions will be very, very straightforward. All the information you need will be in the questions. You don't have to elaborate or think about what I'm trying to ask because they're very straightforward. There'll be history questions on there, diagnostic testing, physical exam questions will be on there. As you can see, there's not a whole lot of medications in this unit so far. There haven't been a whole lot of medications. A lot of it has been just a lot of pain management, patient education. So focus on those things. In the next unit, when we get to strokes and seizures, that's when a lot of the new medication, well, the medications will come into play. When we get to headaches, a lot of the medications will come into play there when it comes to like migraines. So The medications are coming, but they're really not here a whole lot in this first unit. So the big thing is, remember we talked about in class, when the questions come on, remember what side are we talking about? Is it right side versus left side? Where is the lesion? I'll always give you a landmark. T10 is the big one because it's easy. So if I say you have a lesion here, where are they going to have deficits going down? And so forth. So just orient yourself on these questions, where you are in the body with regards to the question being asked and the deficits. Make sure you remember what pathway all those sensory things are in, what pathways they run in. For the big thing with the disorders of equilibrium, again, just differentiate, is this a peripheral or is this a central problem? So understand the different types of vertigo versus dizziness. And obviously the big things for treatments is going to be a lot of what they're feeling when they get all the vertigo, the symptoms. When it comes to the Dawson fingers, it's due to the demyelination of the cell bodies, or all the axons. I'm trying to find, there they are. Yep. Those plaques, demyelination. And the Dawson's fingers are also usually just only associated with MS as well. So if you ever see anything about Dawson's fingers, just know that we're mainly going to be talking about MS in that case. Make sure you don't forget the first lecture with the developmental anatomy stuff. The development of our spinal cord, peripheral nerves, brain, some of the developmental structures we talked about. It should go a little hand in hand with what, well, you guys are doing that tomorrow. Okay. And with peds, you had a little bit of developmental anatomy as well. Anything else? Mainly. This is a key one. Understand what Dick's Hallpike is. What kind of symptoms do they have? And then the peripheral ones versus central. For the neuromuscular disorders, we went through them. Just each one's pretty basic as far as straightforward of what you have to know. Just know the key things for all these ones. These are all peripheral nerve problems. And spinal cord stuff. Make sure you also know from this one, I think that's this one, the major nerve roots we talked about. So like the bicep tendons ones, the major C5. So if I said like in class, if they can't do certain things, what nerve root could it be, and so forth. For caloric testing, if the cold water is poured in an ear and the eyes don't have nystagmus away from the ear, there's a problem on that side, yes. On the side of the lesion. So they should have some bouncing. It means that there's the vestibulo-ocular pathway is intact. When you put it in the right ear, if the right eye bounces, it means it's intact. Left ear, you put it in, nothing happens. The left ear or the left vestibular pathway is the one that's messed up. You're going to have to know this for ortho as well, the nerve roots and stuff. So you're going to get it in both classes. It'll repeat. No, you don't do caloric testing in PD lab, unfortunately. If that's something you want to request and do, you can ask Professor Kim. We'll see if we have the right tubing for the syringe to go in the ears. But, I mean, we can add that to testing if that's something you guys want to do. And add it to your PD lab. Any other last minute questions? You're welcome, guys. Okay, well, I don't see anything for questions, so we'll call it now. Thank you guys for showing up, and I will see you guys bright early in the morning. Dress warm. It's going to be freezing tomorrow morning. And I will see you then. Have a great night.